Hello, everyone, and welcome to the CIHQ Partner Webinar Series. We're pleased to present Mary Ellen Ellen Andrus Martins, Partnering for Patient Safety, Collaborating with a PSO. Please use the question pane to ask any questions. They will be answered either as they arrive or at the end of the broadcast. This broadcast is being recorded and will be loaded to YouTube within a week. Ellen, you have the floor.
Thank you so much, Michelle. Welcome, everyone. I'm Ellen Martin. I've been a registered nurse for 37 years. I can hardly believe it. The last 25 years or so, I've been working in quality and patient safety in acute care, community mental health, home health, and hospice. Since 2019, I've been the director of the federally listed A&M Rural and Community Health Institute Patient Safety Organization. So we're PSO number 79. And I hold certifications in quality and patient safety. And I'm so pleased today to speak with you all about partnering for patient safety and how you can collaborate with a patient safety organization. Our learning objectives for today are we're going to identify the key functions and benefits of a patient safety organization, including the legal protections and confidentiality protections they offer under the Patient Safety and Quality Improvement Act. And then we'll describe the process of working with a patient safety organization to ensure alignment with regulatory requirements, your safety plans, and your quality initiatives. And then our outcome is that you'll obtain a basic understanding of PSOs, enabling you to enhance patient safety and quality of care within your institution. And we know that you do all this already as accredited providers, but this is an enhanced level of protection. So first, we're going to do an introduction to patient safety organizations. I don't know about y'all, but I've been a nurse for a pretty long time before I'd ever even heard of a patient safety organization. So we're going to talk about what is a PSO and what's the role of a PSO in improving patient safety. And I'll talk a little bit about how patient safety organizations came to be in the first place. So a federally listed patient safety organization is an entity that's authorized by the Agency for Healthcare Research and Quality to work with healthcare providers to improve patient safety by encouraging data reporting and data analysis. The mission and primary activity of an entity that wants to be listed as a patient safety organization must be to conduct activities that improve patient safety and the quality of healthcare delivery. There are some organizations that are prohibited from being a patient safety organization, specifically in the law. For example, an insurance company cannot be a patient safety organization. And the reason for that is that their primary activity is not improving patient safety and quality of care. There's also a requirement that federally listed patient safety organizations use a qualified staff. And we collect patient safety work product, and I'll talk a little bit about what that is, from providers in a standardized manner that permits valid comparisons of similar cases among similar providers. And that's what the little logo, the ARC Common Formats is. We use a standard data set called the Common Formats for Event Reporting, and it's a standard data set for comparing events. And then we provide feedback and assistance to providers to effectively minimize patient risk. So these are the requirements of any federally listed patient safety organization. There are a lot of organizations that can call themselves a patient safety organization, but the federal listing means that we've been applied and approved through the Agency for Healthcare Research and Quality, and we are federally listed on their website. So how did patient safety organizations come to be? Well, the modern patient safety movement emerged in response to growing recognition inherent in the risk of healthcare systems. In the early 1990s, there were several, confluence of events. There were some really high-profile patient safety incidents in the 1990s. Harvard published the Harvard Medical Practice Study with Lucian Leib, and one of the things that was in that study was the importance of individual errors and before that study was published, people really viewed medical errors as isolated incidents that were caused by individual mistakes. And that Harvard medical practice study really shone a light on how frequent medical errors are. The Dana-Farber Cancer Institute is world renowned as a cancer treatment organization. And in 1994, Betsy Lehman, who was a Boston Globe health columnist, a beloved columnist for the Boston Globe, was undergoing treatment for breast cancer at Dana-Farber. And during her chemotherapy, she was accidentally given a 4-fold dose of cyclophosphamide for her cancer treatment. And that error went undetected for several weeks, and they could not figure out at first what was wrong with her. And she ended up dying as a result of that. Another patient during the same period also received the same overdose and suffered severe toxicity, but she didn't die. So that was very highly publicized. The Institute of Medicine published a report called Quality of Healthcare in America because there were a lot of organizations increasingly concerned about error. The Centers for Disease Control that year also published a report on blood transfusion errors and the frequency of type and cross-match errors. There was a lot of pressure on the American Medical Association, and the president of the American Medical Association was interviewed on TV and asked, what are y'all going to do about these medical errors? And so they convened the Annenberg Conference on Medical Errors and really had a good discussion about what would need to be done. At that same time, congressional hearings were happening. Our previous executive director here at the Rural Community Health Institute was Dr. Nancy Dickey, and she was the first president of the American Medical Association and the first woman president, of the American Medical Association, and she testified in front of Congress in those years. The Willie King case was a notorious wrong-sided surgery case that happened in Florida. So the National Patient Safety Foundation was organized with the American Medical Association. A couple years later, the Veterans Administration opened a Center for Patient Safety. And during all of these national media, national discussion on healthcare safety, one of the big issues was the cost of healthcare. And prominent employers and healthcare purchasers, Business Roundtable, the Robert Wood Johnson Foundation, and the Commonwealth Fund gathered together to form the Leapfrog Group. And one of the things that was well publicized was how expensive healthcare was. There was an article in Time magazine about how, almost $1,000 of the cost of a new car was for the healthcare for the workers who worked on that car. So all of this is the decade leading up to 1999, 2000, when the Institute of Medicine report was published. And that was really a groundbreaking report because that's the report where they said between 44,000 and 98,000 Americans every year die from medical errors. So that's the equivalent to a jumbo jet crashing every single day. And we don't hear about it because it's hidden away in hospitals, but it's the third leading cause of death in the United States. For a while, COVID knocked it out of third place down to fourth place, but it's back in third place and cost the U.S. healthcare system almost $20 billion a year in avoidable costs. And many patient safety events go unreported due to the fear of consequences of reporting. One of the things to err is human. Building a Safer Healthcare System, that report said, was that to foster participation in voluntary reporting systems, sort of like the aviation industry has with the National Transportation Safety Board, that Congress should enact laws to protect the confidentiality of certain information, because without that legislation, healthcare organizations and providers would be discouraged from reporting errors out of worry that the information they provided might be used against them and be subpoenaed and used in lawsuits. So that Institute of Medicine report to Err is Human had recommendations. And recommendation number 6.1 was that Congress should pass legislation to extend peer review protections to data related to patient safety and quality improvement, collected and analyzed by healthcare organizations for internal use or shared with others for the purpose of improving quality and patient safety. And they went on to say that unless there's protection, people are going to be reluctant to discuss, and that opportunities to learn would be lost. And so if there was this more conducive legal environment, then there would be an improvement in patient safety. So Congress did pass a law, and it was the Patient Safety and Quality Improvement Act of 2005. So lots of congressional hearings. It took about 5 years to get this law passed. It was nearly unanimous in the House. There were 3 people that voted against it, but otherwise pretty unanimous. And what this law did was authorize the development of patient safety organizations and extended this protection to sensitive information about safety events that's designated as patient safety work product. So that's a legal, what they call a term of art. So if you hear patient safety work product, you know that it's about information related to this protected information from the Patient Safety and Quality Improvement Act. So there's 2 main protections. There's a protection from disclosure. So there's confidentiality protection for providers, and there's protection from discovery in civil, administrative, or disciplinary proceedings, except where specifically permitted. And there's some permissible disclosures that are included in the law, and we'll talk about some of those. And then there's some things that can't be protected, and that preserves patients and family rights. And so we'll talk about those too. But the strong legislative intent was that the strong privacy and confidentiality protections would encourage greater participation by providers in reporting, examining, and learning from patient safety events. So patient safety organizations have been around almost 20 years. It'll be 20 years next year. So how do these protections work? So to get protection for this patient safety work product, the sensitive information about safety events, the patient safety organization helps the patient safety organization member establish a patient safety evaluation system. All organizations in healthcare already have a patient safety evaluation system, because all it is a concept defined as the processes and systems used to that an organization uses to collect and report safety information. And so every organization, because of licensing requirements, and if you're Medicare certified, the Medicare conditions of participation require organizations to have a quality program where they collect information on incidents, patient safety events. And so the patient safety evaluation system is the method by which sensitive information is protected in accordance to this law. And even though the law doesn't, for those of us that are legal nerds, we want to go and read the exact law and exactly what it says and what it requires. And so it doesn't require that an organization formally define what your patient safety organization evaluation system is, but it's considered a best practice. And through case law, we've learned that it makes it easier for the judge to see what the hospital's intent was, as if it's clearly lined out. So a patient safety evaluation system looks a lot on paper like an org chart, and it's really just lines out who are the people and what are the committees and the organizations within a hospital or a hospital system who have access to this sensitive information that we're calling patient safety work product. So what exactly is patient safety work product? It's any data, reports, records, memorandum, or analysis, like a root cause analysis, and many of y'all probably conduct a root cause analysis if you have a serious safety event, or a proactive risk assessment. It's also called a high-risk process analysis, or any kind of written statements or any copies of that kind of information that could be used to improve patient safety, healthcare quality, or improve patient outcomes. The law doesn't say that it has to improve patient safety, just that it could improve patient safety. The definition, of course, with legalese, it goes on to say that it's assembled or developed by a provider for reporting to a PSO, and it's reported to the PSO, or it's developed by us, by the PSO, and shared with the provider. So everything that we prepare for our members is also protected patient safety work product. And then also what's protected is anything related to deliberations and analysis of the patient safety evaluation system. So to make all that legalese converted to real life, take the example of a patient safety event like a fall. So what's protected is all the information in an incident report. For us, our patient safety organization members use our system is called the Safety Net, Patient Safety Event Reporting System, but it doesn't have to be our system to be protected. Lots of patient safety organizations have their own system. We actually do have a member that uses a different patient safety event reporting system, and they just run a report every month, and then they report, they share an upload file with us, and so that's the way they report their events to our PSO. What's not protected is the things that preserve patient rights. So if you'll remember from HIPAA, patients and families have a right to their medical record. So when a patient falls, the nurse is going to document in the record the details of the patient fall, any kind of clinical assessment that the nurse did, any kind of actions and notifications that the nurse made. So suppose the nurse notifies the doctor and the doctor recommends that the patient get an x-ray and ice and Tylenol. So those things are not protected because it's part of the patient record, and that's outside the scope of protection. So patients and families always have the right to their medical record. What's also not protected is information that is not for the purpose of quality improvement and patient safety. So things like billing records are not protected. And then things like an action plan, you wouldn't want to protect those because you want to be able to share with the public or whoever's interested, maybe in your maybe on your website or in your hospital's annual report, information about things like your fall prevention campaign. So action plans and activities that you're doing are things that you'd want to share widely. So you wouldn't necessarily want to protect those. But what is protected is when the information from the record is looked at by the quality department, and maybe they fill out an audit tool about whether or not the patient was on medications and whether or not the patient had called for assistance, any kind of witness statements, any kind of aggregate or trend reports, maybe the committee meeting minutes where they talk about why do so many patients fall post-operatively when we are very diligent about telling them to call for help. And those kinds of things. So all of those informations, discussions, root cause analysis, all of that can be protected. Also, information can be protected that's pulled into a committee meeting. So a copy of things like the nurse call bell log from the nurse call system might be pulled into a meeting and discussed there. So the copy of that patient call information and the discussion around it can all be protected. There are three ways that organizations can be, that information can become patient safety work product. So there's three pathways. The reporting pathway is everything that's reported to a patient safety organization. So we have members who report in TSN and the Safety Net online event reporting system, and they might upload, maybe there's a safety event and they might upload a copy of their root cause analysis with it. They also can submit root cause analysis to us, and we will do a gap analysis for them. So any kind of information that's reported to the PSO can be protected. Then any information that is considered deliberation and analysis, so any of your meeting minutes where you show in your minutes that you've discussed the safety issue, that can be considered patient safety work product, and we recommend that that gets labeled. So when a new member joins the patient safety organization, we walk through all of this. How do you make sure that you are enabling all the protections that you want? And then the patient safety organization pathway is everything that we prepare and submit back to the organization. So just a quick summary of what is protected and what the limitations are protected. Everything inside the box is protected. Scorecards, interviews, trigger tools, drug utilization reviews, core measures, safety meetings, root cause analysis. All of those things are for the purpose of quality improvement and patient safety. When you're thinking outside the box, those are the things that are not protected. So the facts in the medical record, patients and families have that right under HIPAA. Administrative practices and logs and documents like billing records, you know, biomedical monitoring for equipment, those kinds of things. And then written information relied on for treatment decisions is also not protected because it's almost like a fact in the medical record. If there's a referral letter from one physician to another physician about a patient, even though it's not inside the record, that physician who's receiving the patient is using that information as if it was a medical record. And then, of course, this was not designed to hide bad actors. So providers acting below the standard of care or criminal activity is not protected. So you can't use this law to protect criminal activity. So before we move on, I just want to pause for just a minute and see if anybody has any questions about patient safety evaluation systems, your method by which information is analyzed, or patient safety work product. And if y'all want to think about it, you can type your questions into the question feature. And Michelle, you can stop me if we get a question, okay?
Yes, ma'am. There are no questions in the queue.
Okay, thank you. So just to sum up some of the legal considerations, these protections apply in both state and federal proceedings. So in peer review statutes vary by state. And so some states have very strong peer review statutes, and some of them are not as strong. This is a federal sovereign protection over and above the state statutes. You can't waive these protections. So the protections attach to the information, not to a person. So the information itself is protected, patient safety work product, but it can be disclosed under the permissible disclosures features of the Patient Safety and Quality Improvement Act. So one example of a permissible disclosure is if you want to let an accrediting person, a surveyor, view some of your protected patient safety work products. So maybe there's a complaint survey about a patient fall or a patient injury or patient harm, and the surveyor wants to confirm that you actually did look into that event. So you can, it continues to be protected even if you share the information with a surveyor or under that permissible disclosures. You're also allowed to use your patient safety work product with your affiliated providers. So if you have a rural health clinic that's associated with your hospital and you've got a patient who comes in and you discover that They've got a medication reconciliation error, and they've been getting, they have a prescription for digoxin and Lanoxin, and they've been taking both. So they've doubled up on their heart medication. You can share that information with your affiliated provider and it still be protected. If the protections are greater than those under state law, then the federal protections preempt the state law. Patient safety work product is not admissible as evidence, and it's not subject to discovery. Plaintiffs' attorneys have fought that, and the protections hold up very well in court. And the key to these protections is making sure that the design of the patient safety evaluation system is set up to make it clear what your intent is. And these protections are enforced by the Health and Human Services Office of Civil Rights, and that's the same entity that enforces HIPAA. And Michelle, did I hear you? Do we have a question?
Yes, ma'am, we have a question. Can a state surveyor request to review details of grievance investigations?
So if the grievance is related to patient safety and quality improvement, so we're talking about not about things like a doctor who rolled their eyes or food that doesn't taste palatable. Those kinds of things are not protected. But if it is a patient safety event that is protected, then the surveyor can request to review the details. But if you're a member of a patient safety organization, you can decline to share the details. And the surveyors have been trained, and not, you know how training is, not everybody gets the word, but we do for our members have some survey letters, letters to surveyors. The Joint Commission actually published a position statement that says that they recognize, and all their surveyors recognize, the protections of patient safety work product for patient safety organization members. And so you can ask the surveyor to, you can do a couple of things. You can tell the surveyor, this is what I will share with you, that we investigated it on this date, but we are invoking our privilege under the Patient Safety and Quality Improvement Act to not share the details. Or you can show them the details but not give them a copy, and you can ask them to sign a confidentiality statement. We have heard from our members that there are occasionally a surveyor who refuses to sign a confidentiality protection disclosure, and in that case, then we just instruct the members to write on it, surveyor Ellen Martin refused to sign on this date. But a surveyor, the question is, can a surveyor request to review details? And they can request, but you don't have to share them if they're a patient safety work product. So I hope that answers your question. It's a great question. Thank you.
Yes, there's another. Can you discuss the erosion of the PSWP protections? This has come up a lot over the years and differs by state.
It does. Actually, the protections have held up pretty well. They are always fought in court, and in Florida, they have a tort reform law. So one of the things that can't be protected is mandatory reports. And so when you think about the way that works, if you work in a nursing home and a patient falls and breaks their leg, there's a mandatory state report that you have to make to the state. So that's not protected because that's mandatory. So the facts that you put in that report can't be protected. But what can be protected is your internal discussion on how that happened and more of the details on how often it's happened and those kinds of things. So the protections have held up fairly well. And in certain cases, the courts have ruled that maybe a provider has to give up a copy of an incident report and those kinds of things. that's one of the reasons why it's important to make sure that your patient safety evaluation system is designed well. There was one court case where they said they were going to report it to the patient safety organization, but that they never did. And so the court did not rule in their favor. So there's a lot of case law that goes back and forth. And it is interesting to read the amicus briefs from the Joint Commission and from the Alliance of Quality Improvement and Patient Safety upholding those protections. But in general, they do hold up pretty well. It'll be interesting to see how things change, as the political climate changes. There's a intent towards deregulation, I think, to make a more business-friendly environment. So it'll be interesting to see what the effect on that is. So working with a patient safety organization. So generally it's fairly easy to join a patient safety organization. Most PSOs, and there's around 95 of them now, and some of them are limited to only their own facilities. So an example, the healthcare HCA hospital system, they have their own PSO. And so only hospitals in the HCA system can be members. Walgreens and CVS both have a patient safety organization. And so they track their own medication errors, and they don't allow outside pharmacies to join their PSO. And then other PSOs are considered open PSOs, and anyone can join them. So usually there's some sort of membership agreement involved, and most patient safety organizations work with the new member to integrate the patient safety activities that PSO offers with whatever quality initiatives are going on in your facility. So it really makes sense just for the PSO to learn about the facility and what kinds of safety and quality priorities that facility has. Often the patient safety organization will train staff on things like safety culture, event reporting, and the PSO protections. So really it is driven by the member who joins the PSO. There's different ways of measuring the impact of patient safety collaboration. So one of the PSOs is with Harvard. It's called I think it's called Academic Medical Systems PSO. And so they work with CRICO because they're also a self-insured malpractice insurer. So even though they have to be separate than the insurance company, they can evaluate the effect of their PSO membership on malpractice claims in their patient safety organization. For us, we offer surveys on patient safety culture. One of the things that we look at really closely is event reporting. And so we have some members that are rock stars at event reporting, and they report everything. And then we've got some other organizations who they'll say, well, we don't really have incidents. And really what it is that they're either not aware of incidents or that they don't report incidents, because research shows that there's a known error rate. For every 100 meds that's given, a certain percent of them are in error. So I think that is one of the best measures is if you can get event reporting to increase, even though it looks like you have more errors, and it takes a little bit of explaining to your board of directors why it looks like your safety events are increasing. Really what that shows is an improved safety culture. Another measure of impact is the ratio of near miss reports to event reports. Research shows that there's about 9 to 10 times more near misses than there are events. So for every safety event that happens, there were about 9 to 10 times when an event might have happened, but because of staff vigilance, a staff member caught it before it became a safety event. And so if you start counting those, and the ratio of near misses to events goes up, then you're showing that you're having a stronger safety culture, because all of this event reporting goes to learning. And so you can learn where the weaknesses are in your safety systems through reporting. So if you can address near misses, then you're improving safety before an event ever even reaches the patient. We also work with providers and their regulatory requirements. So a lot of time is spent, as y'all know, in healthcare organizations working on the things that CMS tells us that we must measure, or with accreditation standards and those kinds of things. So we have members who are accredited by the Joint Commission. We have some accredited by DMV. We have some accredited by CHQ, and then some are deemed status through Medicare. So whatever it is that the hospital's priorities are, that's what we align with and help them. And then also help them navigate any kind of dual reporting responsibilities. And then we provide resources related to quality and safety requirements. So part of the benefit is access to subject matter expertise. So I may get a call from one of our members about patients ingesting foreign objects. And so because we're affiliated with an academic medical center, I have access to full text journals and those kinds of things. So I can do a literature review on things like ingesting foreign bodies or something like that. So that brings me to this idea of choosing the right PSO. So it's really important to think about what it is that you want out of a patient safety organization. A lot of patient safety organizations are niche or specialty patient safety organizations. Most hospital associations in many states have a patient safety organization. So for example, the Texas Hospital Association runs a patient safety organization. Our patient safety organization at ARCHI focuses on the vulnerable and underserved populations. And so we have rural hospitals. And so members of ours who have been at other patient safety organizations appreciate that we focus on under-resourced organizations and offer support for rural health. And also we have several members that are state psychiatric hospital systems. So we have the state systems in 3 different states. And people sometimes ask, well, gosh, what in the world do those have in common? But what they do have in common is they don't have enough staff. They don't have enough resources. They're limited in their financial funding, and they don't do things like maternity services or open heart surgeries and procedures and things like that. So a lot of the information is the same. They're all interested in improving quality and safety, improving high reliability, improving just culture, and those kinds of things. I got a call not long ago from a full service hospital, and she wanted to know about how to join our PSO and that kind of thing. And I talked with her about how really it would be better for her and for her safety program to join another PSO that offers a full service hospitals, because a lot of what you learn is the collaboration and shared learning. So there's a dental PSO. Texas A&M School of Dentistry asked about joining our patient safety organization, but there's already a specialty organization for dental, American Dental Association patient safety organization. So really that would match up better with their goals and need for resources. There's specific ones for anesthesia, there's specific ones for ambulatory care and surgical care and those kinds of things. So you really want to evaluate the patient safety organization's expertise, their focus area, and then the resources they provide. Some of them, like ARCHI, is now merged with the Institute for Safe Medication Practices, and so they have a lot of really, really great resources. So ours is not quite that fancy, but it is definitely affordable. So we're proud of the work that we do. There, you do want to make sure also that the PSO is federally listed. So that's another criteria for making a decision. So the benefits of working with a patient safety organization, just to sum up a little bit before we get to some questions and answers, is the confidentiality protections under the Patient Safety and Quality Improvement Act. As the person asked, you know, they are challenged. Um, just because the plaintiff's attorney asks for information doesn't mean that they're going to get it. So, you know, that's part of it. Sometimes the plaintiff's attorneys will ask for everything, but they'll get information a different way through depositions and those kinds of things. So all of those pieces work together in terms of lawsuits. And then there's this idea of encouraging the open reporting of safety events and the aggregate reporting. So one of the things about safety is, I love this little quote, safety is when nothing happens, because safety is an emergent property of safe systems. And so working with a PSO really helps you with the expert analysis and support, expertise in safety science. We've done educational programs on things like human factors. One of the things that we really enjoy doing is working with other patient safety organizations to offer what we call safe tables, where everything that's discussed in a safe table happens under the umbrella of the patient safety organization. So we've done some safe tables on things like workplace violence prevention, things like infection control, surgical misadventures, patient elopement, lots of different ways for shared learning. So you don't have to wait for something bad to happen at your hospital to learn from it. One of the things that happened after the Redonda Vaught case in Vanderbilt, where the nurse Redonda Vaught gave a paralytic medication to a patient in a radiology procedure, all the way across the United States, organizations looked at making sure that they do not have paralytic agents in locations in their hospitals where, except in places where a patient could be easily intubated. So lots of safety practices get shared that way. So you don't have to wait for something bad to happen at your hospital. Lots of sharing of evidence-based and promising practices. So sometimes there's not an evidence base, but there's always more information coming out in the literature. And then we also do a lot of environmental scanning. So in the last couple years, Safer Together, the National Action Plan for Patient Safety, was published. And the thing that was really great about that from a quality director's point of view, I've been around for a long time, and there's been lots and lots of national action plans, but this national action plan actually came with a self-assessment and an implementation guide. One of the first recommended tactics for implementation was establishing a just culture. And so this year we're starting a just culture collaborative that we're recruiting for right now. So if you're interested in just culture and you think you might want to be part of the collaborative, please contact me after this session. And so that's what we're focusing on next. And then also, as all of y'all know, the new CMS patient safety structural measures have just been published. So there's a lot in the literature, a lot coming out. The national conversation now is on diagnostic excellence, and for rural hospitals, there was just a report published on diagnostic safety in rural healthcare. And when you think about what happens with rural patients or patients who live in rural areas, sometimes they go to regional referral centers to get things like a biopsy or other kinds of care or treatment, and they may not always get information back about how their tests turned out. those kinds of things. So the follow-up can be fragmented unless they're in an affiliated system. And so there's a lot of information about the challenges related to diagnostic safety in rural healthcare. So we're always on the lookout for more information, and always looking forward to listening to our members and what we can do to help them. So with that, I invite you to ask me anything about patient safety organizations or patient safety. While y'all are thinking about your questions, one of the things I like to share is our Texas A&M Century Tree. And the reason this resonates with me is because we teach root cause analysis. And you think about when you do a root cause analysis, the roots are always hidden and under the surface. And what you can see is usually just a fraction of what's underneath the surface. And so this century tree, I don't know if you can see underneath the bench of it, is where a lot of people here at Texas A&M have are proposed to, and those kinds of things. So it has a lot of significance for us here at Texas A&M. And I invite you to connect with me on LinkedIn. I always want to hear from the people who I consider my tribe, are the quality and safety folks. And in many organizations where I've worked, you know, you're the only person to talk about it with. There's not a lot of other people in your organization who gets it sometimes. So, you know, it can be a challenge. It's always fun to work directly with providers in an organization, but sometimes it can be a lonely place to be. So with that, what other questions do you have? One of the, let's see, one question, does indicating PSWP in the subject line of an email afford the discovery and disclosure protections to the content of the email? That's a great question. And the law doesn't specify that you have to label information as protected patient safety work product. So if it's not labeled, that does not mean that it's not protected. It could still be protected. What case law has showed us is that if you do label it, then it makes it clear what your intent was, that your intent was to protect it. So the subject line doesn't afford the protection. It's your membership in the patient safety organization and your intent to improve quality and patient safety that affords the protection. But it is a good practice. And so we recommend things like, lawyers have told us, if a document is labeled at the top of a document, patient safety work product, then everything below that is considered protected. Where if you label it at the bottom of a document, an argument could be made that everything that appeared above that line might not be protected. So lawyers are really, really smart, and they are very invested in helping their client. So there is no end to the clever kinds of challenges that can be made. And so that's why we recommend putting PSWP in the subject line. We don't email things. We use shared things with our members, like shared drop boxes and things like that. So I might send an email that says PSWP, and in the email it says I've shared a document with you in your Dropbox account, or your shared via OneDrive, and those kinds of things. Inside an organization, you usually have some kind of protection, encryption and emails and that kind of thing. The other reason it's a good idea to label things as patient safety work product is if something is challenged and your lawyer is working with you, it makes it really easy on your lawyer to sort out what it was that you wanted protected and what you didn't care about being protected. So it just narrows down the window some. Let's see. So great question. Thank you.
Yes, I'm sorry I was muted earlier when I was asking that. So
Oh,
here's another. How do these protections differ from the Ohio Revised Code protections? Is it just state versus federal level?
yeah, those all of those state statutes are state level statutes. In some states, the protections are stronger, um, but a lot of times they're varied. Like in the Texas peer review statutes, the peer review protections are strong for doctors, but they don't cover home care agencies, and it doesn't cover hospice agencies. So sometimes they're limited, like only for hospitals and not for other provider types, like advanced practice nurses. Um, so those kinds of things make a difference on the protections. And I'm not familiar with Ohio. Um, I know that Pennsylvania and Florida are two of the states where they are frequent challenges to the Patient Safety Act. And the judges in Florida are particularly pro-plaintiff oriented since the tort reform laws have been enacted, which I think may change as the government switches towards more business, but I don't know politics. I used to work at the Texas Nurses Association, so there's this whole advocacy thing that I just think is really fascinating. And one of the criticisms of patient safety organizations, I sat in on a presentation by the Leapfrog Group not long ago, and one of the criticisms of patient safety organizations is the way that some systems use their PSO. So, some of those big hospital systems like the Ascension system and the HCA system, there's a criticism that those PSOs use it to prevent transparency and to hide patient safety errors. So there is a call for more transparency. The Presidential Council of Advisors on Science and Technology, they call it PCAST, just published a PCAST report. And in that report, they mentioned patient safety organizations and asked PSOs to commit to bold action to improve quality and patient safety. So our little PSO did get mentioned in that presidential briefing from Patient Safety Day just back in September for our Just Culture Collaborative. But if you go back and read that PCAST report, there is a call for things like a national patient safety czar and a national patient safety board that would be similar to the National Transportation Safety Board so that we could advance patient safety faster. And while I don't disagree with any of that, I just don't see in the current political climate that any that there's going to be any money put towards another federal agency or another federal initiative, even though I think it's really, really important. Um,
All
what
right.
else?
I apologized if you've already answered. Let's see. Can you claim both PSWP and peer protection?
Yeah, so they're not mutually exclusive. We actually do have a contract with one of our members, and we do their they wanted to change the name of it to make it clear what it is they're doing. So they've got a policy written and they call it physician-led safety review. And so their information does have a double layer of protection. And then also that same client, we work with them for nursing peer review services. And so their nursing peer review can be protected also. So remember I was saying, and I could talk about this for like a whole week, but the things like mandatory reports cannot be protected. And so your nursing peer review can be protected, but if you do have to report a nurse to the Board of Nursing, that report to the Board of Nursing can't be protected. And it seems a little confusing because the facts of a case are similar, but information that's protected and not protected can, they call it residing alongside. It resides side by side. So an example of that might be, suppose your hospital had an outbreak of food poisoning. So that would be unfortunate. Some patients got sick, some employees got sick, and some visitors got sick. Well, the temperature logs of your refrigerators are not for the purpose of quality improvement and patient safety. That is a regulatory requirement that if you serve food, that you have to maintain temperature logs. So the log by itself is not protected. It's like billing information. It's it's administrative data. But the team who wants to know how in the world did this happen can pull in a copy of that temperature log, and then they might have a discussion that says, man, ever since Ellen Martin's been out sick, nobody's even checked the temperature log. So we got to have a better system for making sure when the person who's supposed to document the temperatures is out sick, that we have a stronger system in place. So that part can be protected where the other part is not protected. So we help organizations with talking through those kinds of things all the time. So people just call me and they say, here's the deal. And our conversations are always protected and always confidential. And so they'll tell me what the deal is, and we'll just talk through what the best thing is. Sometimes people will call and say, our surveyor wants to look at this, and here's why I don't want to show it to them. And so we'll talk about strategizing. I've been there with a surveyor, and when they want something, you want to cooperate. You don't want to antagonize the surveyor, of course. You want to be cooperative and give all you can, but you can, how do you word it so that you can be careful and give part but not everything? If a complaint surveyor is there doing an investigation, you don't have to hand them the whole investigation on a silver platter either. So it's a great cooperative relationship, and I learned so much from our members too. So I feel like I share what I've learned over my career, and then I learn from them every day. So it's really, really a great collaborative partnership.
Okay. Can primary care clinics not under a hospital be part of a PSO? If so, which PSOs are available?
Yes, and there is a patient safety organization for ambulatory. I'll give a shout out to Safer Care Texas. They're affiliated with the University of North Texas Health Science Center, and Safer Care has a PSO that they started with their primary care clinics for their medical students, and then they also have emergency services and ambulatory services. So we serve patient safety organizations who have rural hospitals and rural health clinics, but right now I don't have any members that are just primary care or rural health clinics. So yeah, there's a lot of choices there. If you're interested in looking at all the different patient safety organizations, if you go to the Agency for Healthcare Research and Quality, AHRQ, or you can just Google AHRQ PSO listing, it will come up with the list of all the federally listed patient safety organizations. And I'm pretty sure that it doesn't, I'm not sure, but I'm pretty sure it doesn't list the ones that you can't join, like Walgreens and stuff. I don't think it lists the closed ones. I should check on that though.
Here's
And
another.
it says if they're open. Yes, go ahead.
Okay. If I submit a peer-reviewed case into PSO, what type of mechanism would you recommend that we can establish so we don't forget which cases were sent to PSO, because we might accidentally disclose the case for executive discussion in case requested by executives to provide the peer review form that we have submitted? I believe once the case is submitted to PSO, it has a federal level protection, and thus we are not supposed to disclose the case to anyone, even for internal investigation, in case the executives want to investigate.
Oh, that's a really good question, a really good question. Sometimes people get mixed up between the difference between a disclosure and a use. So you can use your information inside your patient safety evaluation system. So if your board of directors is included in your patient safety evaluation system, then sharing that information is not a disclosure, it's a use. And so that's a good thing to talk about with your PSO. A lot of organizations keep a PSWP log so that they can distinguish what they're using, what they're protecting, and what is not being protected. In California, for example, there's a requirement that root cause analysis is done for OSHA. So Cal OSHA has its own requirements for root cause analysis. So when I was saying earlier that a root cause analysis could be protected, that's true in Texas, but it's not true in California if it's for OSHA, for a workplace injury for OSHA. So that's one of the reasons why you might want to keep a disclosure log or a use log. And the other thing could be to label it as such. It's a good idea to keep things separate. So keep them in separate folders in SharePoint or OneDrive and those kinds of things. So great question.
Okay, here's another. Is the employee health record protected from nursing boards? Additionally, is it protected internally in the event it is being asked to share a list of employees who have accommodation requests? Of
Yeah.
course, go ahead.
Go ahead. Yeah, I'm sorry.
Okay, of course, the direct manager is notified. What about if there are other key leaders inquiring, knowing this also may be state driven?
Yeah, that's a really good question. And any kind of employee documentation is not for the purpose of quality improvement and patient safety, so it can't be protected as patient safety work product. So employee records have their own kinds of protection under HIPAA and HR confidentiality laws and those kinds of things. So you'd really want to work with HR on those kinds of protections. So it doesn't fall under this PSO part of the protection. And if an employee record was pulled into an RCA for some reason, only that copy that the RCA team, the root cause analysis team, discussed might that copy would be part of the RCA. Like if you had a, I don't know, an accommodation for a social worker who was blind or something. I'm not sure. I can't think of a good example off the top of my head, but generally employee records are not protected safety work product. Great question.
Right. Yes, very good questions. That is the end of our questions here. Everyone, please take down Ellen Martin's contact information and feel free to reach out to her. This has been recorded and will be uploaded onto the CIHQ ARS YouTube partner webinar channel within a week. Have a great day, everyone. Thank you for your time.
Thanks, everyone. Bye-bye.